Can we just get started?
Yep, go straight in.
Third leading cause of death, $2.2 trillion in spending by 2050, every 40 seconds. These statistics all have one thing in common, stroke. Good morning, everyone. I'm Dr. Michelle Shaw, Chief Scientific Officer of NovoView Diagnostics, a diagnostic medical device company focused on assessing stroke risk by measuring blood flow in the eye. Our novel patent-pending iFlow technology will allow healthcare practitioners to catch impending strokes early, thus reducing human suffering and financial burden. We will leverage iFlow's superior value propositions in the $12 billion market for stroke risk assessment by first targeting our strategically chosen entry market. We have a working prototype in place and a clear path to commercialization. Our founding team combines over 30 years of clinical, technical, and business experience, and we're dedicated to driving our company towards our vision. In order to meet our mission, we're asking for $3.75 million in funding. With the potential exit at end of year 5, we can offer our investors an estimated internal rate of return exceeding 100%. While we're talking to you today, more than 50 patients will have suffered a stroke. Shockingly, 80% of these strokes are preventable. The problem is there's a lack of effective screening tools on the market to catch these strokes before they happen. Strokes are often called a brain attack. When a patient has a stroke, there's an abnormality of blood flow in the brain. Science has shown that there's a significant correlation between blood flow in the eye and blood flow in the brain. NovoView has a patent to a technology which allows us to measure blood flow in the eye and thus potentially assess a patient's risk for stroke. Our novel patent-pending iFlow technology combines a slit lamp biomicroscope coupled with a high-speed camera. That camera captures 60 images per second of the microvessels in the conjunctiva, which is the white part of your eye. After those images are captured, they're then uploaded into our proprietary software and analyzed using spatial temporal imaging techniques along with our proprietary algorithms in order to ultimately determine blood flow. You can see here what we see when we upload those images into our software. Here it looks like traffic, but that's actually individual red blood cells flowing through these tiny microvessels. We're able to look at these vessels and calculate blood vessel diameter, blood vessel velocity, and then ultimately blood flow.
Today, the American Heart Association is already recommending to screen everyone older than 45 for their risk of suffering a stroke. Our technology can find application in this market for stroke risk assessment in the general population worth $12 billion for the US and the European Union alone. We plan to place our technology in primary care settings and optometrist offices, making it part of everyone's annual checkup. Much like your routine blood flow, blood pressure measurement, a few seconds suffice to look at the patient's eye, take the images, and have algorithms analyze your blood flow. This preventative focus is very much aligned with the current implementation of nationwide accountable care organizations. However, this opportunity poses notable barriers to entry. Thus, what we will present to you today is our go-to-market strategy, showing you how we will get there. Specifically, we have strategically chosen an entry market that allows for relatively quick and easy adoption. Stroke risk assessment in sickle cell patients. By first targeting this niche segment, it allows us to mitigate critical go-to-market threats such as FDA approval, market adoption, and obtainment of reimbursement by the largest extent for several reasons. First and foremost, we will have a high impact on patient outcome. Sickle cell patients are the population with the highest incidence of suffering a stroke. As a matter of fact, because strokes are such an enormous problem in this population, it is the current standard of care to routinely screen these patients. Once identified at high risk, follow-up treatment has proven to reduce stroke incidence by 92%. Thus, we will have a life-saving impact on these patients. Secondly, with the current gold standard, there's a predicate device in place that we can compare ourselves to, allowing for a relatively easy and quick FDA approval process. Thirdly, we have already obtained data in sickle cell patients proving our concept and established relationships with key thought leaders in the industry. In conclusion, once we have gained market access by first targeting this entry market, it will allow us to strategically position ourselves to tap into the $12 billion market by fiscal year 5.
As Dominic said, stroke is a huge problem in patients with sickle cell disease. In fact, pediatric patients with sickle cell disease are 333 times more likely to suffer a stroke compared with a healthy child. The images before you on the left represent sickled red blood cells. These cells are crescent moon in shape, hard, and sticky. Because of this, they have a tendency to stick together and block off blood flow to vital organs and tissues in the body. Now, when these cells stick together and block off blood flow in the brain, they can actually cause a patient to suffer a stroke. This is why stroke is such a huge problem in this patient population. There are more than 12 million people in the world living with sickle cell disease. 100,000 of them are here in the United States. The effects of the disease are so devastating that every child born in the U.S. is screened for sickle cell disease before they leave the hospital to go home for the first time. If it's determined that that child has sickle cell disease, it's recommended that from the age of 2 until the age of 16, that child receive a biannual stroke risk assessment. If that assessment determines that the child is at a much increased risk for stroke, he or she will be put on monthly blood transfusions lasting until adulthood in order to minimize that risk. The problem is many patients don't have access to the current medical technology that's being used to assess their stroke risk. Jimmy is one of those children. Jimmy didn't have access to the device, and thus he suffered a stroke. This is not an uncommon story right here in the United States. In fact, 58% of pediatric patients are not being appropriately screened for stroke risk. This is not only leading to unnecessary morbidity and mortality in this patient population, but it's also leading to an unnecessary financial burden. The current gold standard technology, which Dominic was referring to, that's being used to assess stroke risk in this patient population is transcranial Doppler, or TCD. TCD uses ultrasound technology in order to measure blood flow in the brain through the skull. There are many drawbacks to this technology. Its high cost makes it unavailable to many patients. It also has a limited scope, and it's been said to be one of the most difficult ultrasound studies to perform.
So let me demonstrate the iFlow's superior capabilities over TCD with the example of Jimmy. So Jimmy is 14 years old, lives in rural Illinois, and is getting ready to get his biannual stroke risk screening done. To do so, he needs to travel to Chicago for 3 hours because his local community hospital is not offering TCD because they don't have the highly skilled professionals needed to administer the test. So once in Chicago, Jimmy has to lay still for 45 minutes, allowing for the highly skilled sonographer to administer the test. Once Jimmy and his family is on his way back home, a second professional, a radiologist, is taking over to subjectively interpret these results. At the end of the day, both parties will have incurred high costs. Jimmy and his family by actually traveling to Chicago, which is something that might have deterred him from getting the test done in the first place, and the hospitals by paying both sonographer and radiologist. Unfortunately, Jimmy can only get the test done until he turns 16 years of age because after that, his skull will have become too thick to properly administer the test. Now, the same scenario after introduction of the iFlow. Jimmy can now go to his local community hospital because it has now become attractive to offer the technology as it's offered at a much reduced price, and as now there are no highly skilled professionals needed anymore, as the iFlow software is automatically calculating the results in less than 5 minutes. Also, there's no limitation in scope anymore, as the iFlow is not reading test results through the skull. The scenario that I've just laid out for you offers value propositions for all major stakeholders. For hospitals that currently offer TCD, the iFlow will create cost savings of 50% as it's less personnel intense and quicker to conduct. For sickle cell centers and community hospitals, we are now offering an additional revenue source as they're currently referring their patients to radiologists. That will entail more patients being screened and more patients having access to the technology, resulting in less mortality, which then creates cost savings for the entire U.S. society of $200 million and above annually. This truly means that we will create a win-win-win solution for all major stakeholders down the value chain.
What's your accuracy compared to TCD or predictability?
Can you go to the appendix, please?
Yes.
And
can you not do TCD anymore over the age of 16?
Yeah, currently TCD is not recommended for patients over the age of 16.
So what happens to over 16?
They're not screened at all.
Really?
Right. So their stroke risk is not being assessed at all because there's no medical technology in place in order to assess their risk for stroke.
And you can assess that?
We'll have to do a side-by-side study with TCD. However, there have been studies done that have shown there is a correlation between blood flow in the eye and blood flow in the brain. So we're basing our assumptions off of this study, which actually showed that with TCD, if the reading is above 200, which is an abnormal reading, that would correlate to a reading in the eye of less than 0.2 millimeters per second of blood flow.
But you haven't done head-to-head against TCD?
We have not done head-to-head against TCD, but it has been done blood flow in the eye versus blood flow in the brain. But that's worked into our timeline.
Isn't that pretty easy to do on 20 patients?
Yeah, actually, that's our next step. Currently, we've done proof of concept studies in an animal model, and we've tested 60 human patients. But our next study lined up is to compare ourselves head-to-head with TCD.
Who owns the patent or the patent pending on it?
Right, can you go to the slide for the patent, please? Yeah. Currently, we have an option to license a patent from the university. iFlow was developed by Dr. Shahidi, who was on our team, and she continues to work with the product. So we're licensing the patent from the university, and this is something that's been done in the past. Several companies have been launched successfully through this program.
Is there a royalty?
Yes, we have to pay between 3 to 5% of gross revenue in royalties to the university.
And is TCD pretty accurate?
It's not as accurate as the physicians would like it to be. There is about an 82% sensitivity and a 91% specificity. So TCD isn't as good as it could be.
So if let's say yours is better.
Right.
How will you know that if you've got a rubber ruler that you're comparing it to?
Right, that's a great question. So initially, we will compare ourselves head-to-head with TCD because that is the current gold standard, and that's what's being done. If the patients are determined to be at an increased risk for stroke, they're put on those monthly blood transfusions, which will minimize their risk for having a stroke by 92%. So even if there are false positives with the test results, the overall effect is actually really great for these patients because it's not only reducing their stroke risk, but it's also going to help them with other underlying conditions that go along with having sickle cell disease.
What I'm saying is if TCD is inaccurate, measuring you against TCD is, I don't know how you do that.
Right. Like I said, it does have a sensitivity and specificity which are being accepted by medical professionals now. So we would be comparing ourselves against them just because that would help expedite our FDA approval process.
Is TCD the gold standard now?
Yes, sir.
Okay.
So if TCD says yup and yours says nope, how do you know which is right?
Well, that's why we would have to continue to do studies. So currently, right now, they're using TCD, but through our studies, we would establish parameters, which would say for velocities in the vessels in the brain greater than 200, that correlates to blood flow in the eye less than 0.2 millimeters per second. So we would establish our parameters based off of the previously established TCD parameters.
How long prior to a stroke, and I know this is a hard one to put an exact number on, do they start to see the reduced blood flow? Is that like a slow build-up process, and then all of a sudden you'll have a blockage in your artery?
Right. So it's different if you're looking at the general stroke risk population compared to the stroke risk population for patients with sickle cell disease. Mm-hmm. In fact, patients with sickle cell disease, the the process that leads up to their stroke risk is very unknown. There has not been a lot of research out there. But in the general stroke risk population, if we're talking about a patient having some sort of a carotid blockage, that's something that doesn't happen overnight. It progresses over time. But right now, that blockage is not being assessed on a regular basis, which is where we could step in and potentially every year when you go to your eye doctor, we can see how your flow is changing.
But isn't there a test now that measures the carotid?
Yes.
How do you compare to that?
Right. We have a backup slide for that.
Right. So what we actually do is there are two ways that we compare ourselves to. So one is that we said the ultrasound through the skull. One is ultrasound at your neck. So actually the second one is the carotid Doppler that Michelle was talking about, and it's actually very similar. It takes about 30 minutes. It's priced at a higher point, and it's also very subjective, meaning it's very high. It's very tough to replicate. It really depends on the individual skill set of the one who's reading it, and that's actually deterring primary care physicians from offering it right now on a regular level, because on average, when you go to primary care physician or optometrist, you have that's what data indicates 13 minutes every time. So we actually will only take 5 minutes.
I was going to ask a question separately, but now you've got the chart up here. So you were talking before about TCD being $70,000 and yours $20,000. So and here you have it on a CapEx line. Right. So you're amortizing the cost of the equipment over the number of tests. Is that how you're coming up with that $20,000 and $70,000 number?
You mean? So you mean the pricing? So the price. Okay, that's the capital expense.
I think in your other chart you said the cost is for your cost is $20,000 versus the competition being $70,000. Right. Where do those numbers come from?
When we talk about reimbursement, that's two things. So we are charging $70 every time it's being used, charging $20,000 for the device. So what the reimbursement is for, and that's the code 93886, is currently reimbursed for $150. So that's the one we're using. So we're charging $70. What the physician's being reimbursed for is $150.
Mm-hmm. So let's go to the physician. So your strategy in terms of go to market, because it's an ophthalmological device, is to have the optometrist or whoever your eye care professional is administer the test when you're having your yearly checkup or whatever. Is that right? Right. That's the model. So I mean, so today if I go for my eye care, he's got an optional test or two that's not covered by insurance. I think it's $35, and I don't know, pay attention, but I figure for $35 it's worth it. I guess it's worth it. But anyway, but now you're asking that ophthalmologist to perform a test that has nothing to do with the care that he's delivering. Right. Have you checked that out?
We have, and we have talked to, actually we are targeting optometrists and not ophthalmologists.
Okay, so, potato, but yeah,
right,
go ahead.
We have talked to them, and actually a lot of what they do, for example, retinal imaging, reading like your degree of retinopathy, that's something that they do a lot. It's not just, you come in and you get your, contact lens exam taken. It's a lot about medical.
But the reason they're doing that is for macular degeneration, right? Which is an eye care issue. I'm just wondering how you're going to get an eye care specialist to deal with things that are not eye care related.
Right, and that's a great question. Actually, when they're doing the retinal imaging, which is what I think you probably paid $35 for, that can actually assess a lot more. It can actually tell a patient's degree of diabetes, how well they're controlling their diabetes. So it really is a window into the rest of the body. And the optometrists that we've talked to are really excited about offering additional services. They actually already have the slit lamp biomicroscope, which you guys saw here an image of. So for them, we could potentially just be adding on our specialty camera and our software package. So they are very excited about doing that, and for them, it's actually an additional source of revenue.
And would you expect that they would then perhaps refer back to a cardiologist if they see something that looks erroneous?
Right, absolutely. And even with the implementation of accountable care organizations in the United States, this is a really great way for different specialists within the healthcare realm to talk to each other and to work together in order to prevent things like stroke from happening, reducing overall healthcare costs, and then they all share in the benefit of that through CMS.
Can an optometrist use a reimbursement code that's not particular to his business?
Yes, they can.
And why wouldn't you target, I know that they have the split beam scope, but why wouldn't you target getting this to the cardiologists so that they could do this as an outpatient rather than a hospital procedure?
Right, that's a great question. Actually, some of the cardiologists and physicians that we talk to would rather refer it to an optometrist. They see, looking in the eye, I would rather have the optometrist. They're the eye people, let them deal with it. Some of them are really open to having this device. But like I said, with accountable care organizations, the physicians are talking a lot more, even with their charts being, they're able to see charts from the cardiologist and from the optometrist. So it's easier for them to talk now.
So perhaps the optometrist is the easier barrier to entry market?
Yeah, absolutely, especially because they already have part of that hardware in place.
Yeah, yeah.
And I just want to make that a little clearer, our commercialization timeline in a nutshell. So we've touched on it already, that before actually bringing on a seasoned and experienced CEO, before running a clinical trial, we will conduct another confirmatory study comparing iFlow to TCD with, in about 20 patients. And along with Pliet, which is a contract research organization we've already established a relationship with, we will then run a 9-month clinical trial that's very similar in design with the goal to establish stroke risk parameters by correlating iFlow blood velocities to these that have already been established with TCD. That data will then be applied towards FDA 510(k) approval, which we estimate to take 6 months maximum, which will then be followed into, by market entry into the United States and the European Union for stroke risk assessment in sickle cell patients, before we will then conduct another clinical trial in fiscal year 4, where we compare the iFlow to carotid Doppler, so to the second ultrasound technology, again, correlating those two in a very similar fashion. And that then will be followed by market entry into the general population towards the second quarter of fiscal year 5. And by the time we actually have already established relationships with distribution channels that are needed for this market, which are optometrists and primary care physicians. So that's just to clear it up a little more.
There was a statement made that there's nothing for sickle cell disease after 16. I understand you can't use a TCD, but you could use a carotid Doppler,
Right.
couldn't you?
But like I said, the etiology of stroke in patients with sickle cell disease, so the reason the stroke is occurring is much different than in the general population. So they wouldn't necessarily have blockage in their carotid.
So carotid Doppler is not a good test for a sickle cell patient?
Right, yeah.
Can we go to the...
Can you tell me how much capital has been invested so far? And then number 2, is it what equity you're providing for your capital request?
Great question.
All right, so the question is how much equity we're providing. For the
How much equity has been put into the company so far?
Right. The funding has been sponsored right now through NIHI grants that our research has gotten through her department. So there's no specific funding that's been raised for that specific project yet. We are planning on writing an SCTR grant that the application is due June 5th. So we do plan on acquiring more grant funding to really move that forward right now.
Before you move on in answer to his question, comment on the cost impact, if any, the dilutive impact on the grant financing that you've already attained or that you're looking to attain.
In the appendix. So if you go to the current, nope, this one. Okay, so here you'll see for the first round of funding of $700,000, that will buy them 17.5% of the company, and that's the first round of funding where we'll be using to get the human trials. We'll be paying for the patent costs, the back patent costs, and that will be reduced over time when we get the round 300. Round 2 is the $3 million. Their ownership buy-in is going to be at just under 45%.
But this is exclusive of any other grant financing.
Right.
And
This
you're
is total
attributing
fund.
no cost, no dilutive impact at all from that grant. It's purely a grant without any
No. The grant funding will reduce the amount of funds that we'll need overall. So what we projected, what we showed you, or we're about to show you, was total funds needed.
Okay.
So that's, since the grants aren't in hand yet, so if we get more grant funding, it would reduce the amount of money that we would need for that.
So there's no cost to those grants. That's what I'm getting at. There's
Right.
no cost to those grants. They're it's purely grant money.
Sure.
And your company and your investors are going to benefit from that grant money.
Yes, it's all non-dilutive grant funding.
How much of that are you anticipating that you have
$850,000 what we project from the 2 rounds of the SCTR grant. We've also reached out to the Bill and Melinda Gates Foundation. We're reaching out to other organizations like the National Heart, Lung, and Blood Institute and try to drum up as much possible grants as possible. But we feel very confident. We've been working with Annalisa Smera Consulting, who does grant writing consulting, and she feels confident based on where we're at. Once we get some of these milestones in place, that we get about $850,000.
I have another question. Jerry, did you have a question?
No, go ahead.
Can you pull up the appendix that addresses your assumption and financial statements, specifically your 5-year pro forma income statement? It's on page 11 of our package. I just want to make sure I understand how you see these numbers falling out over the next 5 years.
Right. So the one that you have in front of you that's about a month old, so this is our new income statement. We've had some adjustments to the assumptions. So this is breaking it down. We have the IFO equipment sales, the IFO revenue, any specific?
Well, what I was, in my version, you've got year 5 total revenues at $10 million, okay?
Right.
And you've got net income here of $1 million. Do you have those same numbers there? I can't see.
No, we have net income of down to under $1 million, so I think it's $845,000.
845 in year 5.
Right.
So I'd like you to comment, and you're looking for investment capital of $3.7 million to get you to a 5-year net income level of $1 million, less than $1 million. And I'm just trying to intuitively, aside from applying a revenue multiple that's going to, basically be ignorant of what's going to get driven to the bottom line, I'm trying to get a sense for how with 5 years of work and the risk attributable to having that money out there, $3.7 million, you get to something that's meaningful there. That's my first question. My second question is, you've got a balance sheet in the package that shows at the end of year 5 about $8 million in cash. And there's no adjustment to your equity. I thought maybe you contemplated another capital raise, but you're showing that as being financed through retained earnings, and I didn't see where that number came from with the $800,000 in year 5 set forth on that chart, or $1 million in this.
So in our first 5 years, we'll be incurring more costs than will be averaged out after their 5th fiscal year, because we have 2 clinical trials in there that are quite expensive. So that's a reason why our net income from fiscal year 5 is pretty reduced. We also feel that the valuation upon exit is going to be a lot stronger based on the fact that we'll just have eclipsed the general market for stroke risk assessment. So the majority, about 75% of the revenue earned at this point is all from the sickle cell field. So since we're just getting the tip of that iceberg, that we feel that that's when we'd like to pass it off to a company that has a much broader reaching distribution channels and name recognition, and that they'd be willing to pay a lot more than, I think the revenue model.
You're just saying your exit is at year 5 when you've driven basically 7 figures to the bottom line, and you'll let somebody else take it to the next level.
Yes. So yeah, we have the experienced CEO that would kind of take us through there. That, the first year we feel that we can take it through the design of the beta prototype and the first human trial.
And okay, and the numbers here show just a 5x on revenues.
Right.
And so, can you assign some reality to that? Or?
Sure. Let me go to the comparables. So we have some comparables that actually show much larger. I think the average that we got from some of these were about 5.5 from the Hologic Inc. and the Solera. So we use a 5-time multiple. If you also want to see the okay, so this one also will show some things as well for the exit valuation. We know that 3 to 4 time multiple might be a little bit more standard for a medical device company, but since that we're entering a high growth potential field, we've been told by many people that maybe a 5 to 8 is also a possibility for us to get that. So we use a 5-time multiple based on our fiscal year 5 revenue, and all on the bottom you'll see the different projected valuations given different revenue multiples.
Can you go back one slide? So I'm just trying to do some quick math. So these were what? Size of these companies were in the $10 to $15 million range?
Yes. When they exited.
How do you divide that?
Right, just divide them.
And what was your revenue in year 5?
$10.5 million.
Okay, thank you.
May we go back to the competitive analysis grid that shows direct and threat of entry competition?
Sure.
What does NA mean? Oh, I don't.
Not applicable.
Okay. I see that the iFlow, what am I looking at here?
They're just listing our competition, indirect and emerging.
Okay, I'm looking at the one that gives a numerical grade to each of the boxes. This guy.
Right.
So what I'm seeing, though, is that the iFlow versus the laser speckle imaging seems to be the same score for each one, except where it says NA. I don't know what their price is.
Right. The thing is, what we looked at, we want to take a really proactive approach in identifying emerging competitors. Laser spectral imaging is something that has been around for quite some time. And what we looked at is it's currently not being used actually for the eye and not for our application. But what they do is by projecting laser speckles onto your eye, they could potentially do something that we do. However, they haven't moved anywhere in that direction. They just have the mere technological capabilities to do so, but they just haven't done so. They're purely used for research purposes as of now. So really in the research, in the teaching field right now, and there's no information on how expensive that's going to be, how long it actually takes, and what they do with the results and how they're analyzed. So just the technological setup, they could do something like we do. That's why we said NA, because there's no information disclosed.
You know, you guys are very passionate, obviously, about the product, the technology, the general functions that it provides to a lot of very needy people. And what I would, you know, and believe me, we all know that you can create a pro forma to say whatever you really want it to say. But what I would like to really understand just one more time is within that 5-year horizon. Okay, you got less than 7 figures on the exit. Have you built in, or are there unstated or non-stated upside? Is there unstated upside capacity that you're not purposely containing in the pro forma that would impact? You know, because in order to really get a handle on whether there's $50 million of value or $80 million of value after 5 years, there's a lot of comparability analysis that you need to see aside from taking some companies and just looking at revenue multiples, right? You got industry issues, you've got bottom line, you've got prospects for go forward, a whole lot of intellectual property issues. And it's so I just to sum up, what are my upsides if I'm in at 4 million?
Yeah, I mean, we're basing that 5-time multiple, like I said, we felt that it was fairly conservative based on the fact that we're getting $4 million worth of sales into the general stroke risk population when that's a $12 billion market. So right now we feel extremely comfortable with the fact that we could displace TCD in the sickle cell market. So that generation is mostly reflected in our financials, but we feel that that's just, like we said, the tip of the iceberg as far as being able to really go after a huge market.
So you're taking one segment, and are you calling that essentially your worst case scenario, your most likely scenario, your bottom, you know, your lower tier scenario?
Sure.
Is that what you're presenting to us? Is that
well, I
kind
mean,
of an analysis?
We're very confident that there's going to be an application into the general stroke risk population market. We just don't have the data to back that up. So yes, we are very confident in what we presented for the sickle cell market, and that would be almost like a worst case scenario. You're right, where you're going to get maybe a lesser return, but at least become cash flow positive on that.
Well, but you're really confident in the sickle cell market, but there's lots of science that needs to be performed to determine whether this is an effective procedure for other reasons for stroke.
Correct. So with the initial data that we've gotten, it has been in the sickle cell patient population. We do try to de-risk that by doing some more confirmatory studies, some human trials, about 20 patients before we ask.
Yeah, but you've got correlation in the sickle cell market, but you don't have correlation in the non-sickle cell market.
Right, that's
Do
true.
you? I have to ask questions.
Right.
Do you?
But getting into the general population, really at that point, we'll just be almost repeating the same study that we did in the sickle cell patients, but we're going to be comparing ourselves head-to-head with carotid Doppler instead of transcranial Doppler.
What gives you confidence? What in your background, in the science, and the papers, publications give you confidence that it's going to be effective in that market.
Right. So there have been studies completed in science. There's been a couple actually. One that I can note is a study that was done where during surgery they had to clamp off the carotid artery in order to do a brain surgery. And they were able to measure blood flow in the eye while the carotid was blocked off, and there was a significant change in blood flow in the eye. So we do know that there is a correlation between blockage of that artery and blood flow in the eye. So science has been moving in that direction, and studies have been moving in that direction. So we're quite confident that if we do put ourselves head-to-head against the carotid Doppler, we can use their previously established parameters, which are being used now, in order to establish our own parameters.
Would you, by that logic, would you see that you could perhaps apply this in operating rooms with the patient wearing a goggle format to monitor this during the operations?
Right. Yeah, I mean, potentially there could be an application for that. There's currently an application that's being used to monitor blood flow in the brain during surgery in the brain, which are just these applications that are put on the patient's forehead in order to measure blood flow. Mm-hmm. But that could be a potential application to the product. Thank you.